Hello and welcome everybody. My name is Lara DiTomaso and I am a research and policy analyst with the Mental Health Commission of Canada. Before we get started today and I introduce our moderator, I'd like to quickly talk about a couple of housekeeping items and then give you a brief overview of the MHCC's work on expanding access to counseling, psychotherapies, and psychological services. Please remember that the audio for this webinar is provided in broadcast mode through your computer speakers, so you can hear us, but we cannot hear you. If you are having any troubles, check the audio settings on your computer or contact Adobe Connect at the phone number on the slide. Also note that this webinar is being recorded and will be available on the MHCC website in October. Just a few more housekeeping items. Please remember that if you have any questions or comments, please type and submit them through the Q&A chat box on the bottom right of your screen. Note that we will hold most of the questions until the end of the presentation. And please note that you can download the slide deck and references right now by selecting Documents on the right and clicking on the Download Files button. So welcome to the first webinar in a 4-part webinar series on expanding access to counseling, psychotherapies, and psychological services. In recognition of the decades of work already undertaken by stakeholders to expand access to these vital services, in the winter of 2017, the Mental Health Commission of Canada commissioned a background paper which explored funding approaches for expanding access and provided an overview of the IAPT program in the UK and the Better Access program in Australia. This program informed a one-day roundtable held in March 2017, which brought together clinicians, researchers, policymakers, and other key partners to exchange knowledge on best evidence and have a preliminary conversation about expanded access in the Canadian context. This webinar series will highlight the evidence on cost effectiveness and clinical efficacy of psychological services, which we're going to be exploring in detail today. Subsequent webinars will dive into exploring funding options, discuss lessons learned around implementation in other jurisdictions, and address equity issues in the context of expanded access programs. Stay tuned for an invitation to our upcoming webinar. So I'd like to now introduce our moderator, Dr. Karen Cohen. Karen Cohen is the Chief Executive Officer of the Canadian Psychological Association, a position she has held since 2008. Dr. Cohen completed her master's and doctoral degrees in clinical psychology at the University of Windsor. She went on to complete a postdoctoral fellowship in rehabilitation psychology and neuropsychology at the Ottawa Rehabilitation Centre. She holds and has held leadership roles on many health and science-related alliances. She has prepared and presented briefs to many standing committees of the Senate and House of Commons of Canada on matters pertaining to health and mental health. She has also held a ministerial appointment to a national advisory group on disability. Dr. Cohen has written and presented widely across Canada and internationally on the science, practice, and education of psychology and related topics. Welcome, Karen.
Thank you so much. First off, I want to thank the Commission for its leadership in the area of mental health and for hosting this webinar on a topic of really such critical importance to the mental health and well-being of Canadians. Access to mental health services supports in Canada is a problem in dire need of solution. We all know 1 in 5 have a mental health problem in a given year. Only 1 in 3 report that they sought and received help. While stigma surely gets in the way of asking for help, so does the way in which our public health systems respond to mental illness. There are 2 first-line interventions for mental disorders, medications, and psychotherapy, neither of which are covered by our public health insurance plans. We have no pharmacare program, and psychotherapy is largely provided in communities by psychologists and others whose services are not covered by our public health insurance plans. While private health insurance, typically accessed by Canadians through employment, usually has no caps on coverage for medication, most place caps on coverage for psychological services that are too low to afford a sufficient dose of treatment. Other countries have done better, and Canada, hopefully through the new dollars transferred by the federal government to the provinces and territories for investment in mental health, has an opportunity to do better as well. Psychotherapies work, they are effective with a range of problems and disorders, and confer not only great individual and family benefit, but also great economic benefit to the workplace, the healthcare system, and the economy. With us today to talk about the clinical and cost effectiveness of psychotherapy are Drs. George Tasca and Helene Maria Vassiliadis. Dr. Tasca is a psychologist, seasoned clinician, and associate professor at the University of Ottawa. He is the director of the Psychotherapy Practice Network, Research Network. Dr. Tasca has completed and published several randomized controlled trials of psychotherapy and writes a popular monthly e-newsletter on psychotherapy research. Dr. Vassiliadis is a senior research scholar of the Fonds de Recherche du Québec and a professor at Université de Sherbrooke. She is an epidemiologist whose research focuses on individual and population mental health indicators for the purposes of shaping a mental health system that can meet the mental health needs of populations. I will now turn the floor over to our experts.
Thank you for that introduction, Dr. Cohen, and thank you also to the Commission for inviting me to speak today. My primary goals for today are to really talk about the evidence base for psychotherapies and evidence-based practice in psychotherapy, also to critically evaluate the relative efficacy of psychotherapy and medications for depressive disorders. I also want to touch on the merits of looking at common factors across psychotherapy orientations in predicting psychotherapy outcomes. I want to start with talking about the definition of psychotherapy. This is borrowed heavily from the American Psychological Association task force that published a report in 2012. And I'll just touch on a couple of things. They describe psychotherapy as the informed and intentional application of clinical methods and interpersonal stances. It's interesting to note that they not only refer to clinical methods or techniques, but also to the relational aspect of that's key to psychotherapy and its effectiveness. That these are derived from established psychological principles. Well, that makes sense in the sense that there has to be a psychological theory with some empirical support to it, for the purpose of assisting people to modify their behaviors, cognitions, emotions, and other personal characteristics. That's a third one is actually broader than many people might expect, in the sense that it's not just about symptom reduction, but also about other issues, including emotion regulation, quality of life, and so on. So it's a broader, interesting definition that includes a few aspects that many people may not immediately consider. Also, I want to touch on, just very briefly before we get going, a couple of definitions that get conflated, empirically supported treatments and evidence-based practice in psychotherapy. Empirically supported treatments is a notion that developed in the 1990s from the Division of Clinical Psychology of the American Psychological Association when they came up with a list of empirically supported treatments, and they used a number of criteria to come up with this list. There had to be 2 randomized controlled trials supporting the treatment under question, and the trials had to come from different research teams. The treatments had to have treatment manuals. Treatment fidelity had to be assessed. So there's a real value statement in the middle of that regarding manuals and manualized treatments. Clearly defined sample and disorder. Again, very symptom-oriented, based on the development of DSM-3 and 4. And the treatments had to be superior to a placebo control or had to be at least equivalent to another bona fide empirically supported treatment. Evidence-based practice is actually quite a bit different. It includes the integration of 3 things. One of them is the best available evidence research, which is sort of what you would see in the empirically supported treatment statement. But also integrated with the best available research is clinical expertise. In other words, a clinician's expertise in making decisions on an ongoing basis about what and when to provide treatment and to whom. And the third aspect is the patient characteristics. These include various things like personality characteristics, culture, and preferences. And as we'll see later, these patient characteristics, in fact, account for the largest proportion of outcome variance. Now, as far as we know, based on some of the research that's been done in Canada, I would estimate that approximately 1 million Canadians use psychotherapy in a given year. That means that about 5% of Canadians use some outpatient service for mental health beyond seeing a family practitioner. However, the rates of psychotherapy use have probably been declining over the past decade or two. These are data from a paper by Olson and Marcus. These are American data, but probably a very similar situation in Canada. If you look at the left-hand side where it says psychotherapy only, you'll see that the rates of psychotherapy use of people who were seeking treatment in the U.S. declined from about 15% to 10% from 1998 to 2007. And on the other side of the graph, the medication only increased from the low 40% in 1998 to high 50% in 2007. Those gaps or those trends are probably more exaggerated today than they were back in 2007. The first main question, I guess, regarding psychotherapy research is psychotherapy more effective than no treatment? And the answer is a resounding yes. There have been a number of meta-analyses looking at this question. And just as a side note for everyone, if you're looking for evidence for anything related to psychotherapy or medicine, the place to look at are meta-analyses. I wouldn't really spend a lot of time looking at individual studies and trying to make clinical decisions based on that. Meta-analyses are the best, are really systematic reviews that clearly summarize the effect sizes across a number of different studies on a particular question. And so most of what I'm going to be talking about today are based on, the results are based on meta-analyses. The effect sizes for psychotherapy are generally large compared to no treatment. What that means is that the average patient receiving psychotherapy is better off than 79% of untreated controls. That's a general way of understanding that large effect size. The effect sizes are as large or larger than many common medical procedures. These include the use of statins in cardiology, the treatment of asthma, aspirin as a prophylaxis for heart attack, warfarin for blood clots, AZT for neonatal infections, the influenza vaccine, cataract surgery, and so on. So putting the effect size of psychotherapy in that context gives you a sense of the company that it keeps in terms of medical interventions. There are a number of different types of psychotherapies. I'm very briefly going to mention four that tend to be more common. This is not an exhaustive list, obviously. Interpersonal psychotherapy focuses on interpersonal issues that underlie depression. Behavioral activation seeks to increase a patient's positive interactions with the environment. CBT, which is well known and well researched, focuses on largely on negative beliefs and restructuring those beliefs, as well as behavioral interventions. And psychodynamic therapy, which focuses on unresolved conflicts and issues in relationships and how they impact a patient's current functioning. So we know that psychotherapy is effective. Are there any differences in outcomes between treatment types? And the answer generally is no. There are a number of meta-analyses and what are called mega-analyses, which are meta-analyses of meta-analyses of bona fide treatments going back to the 1970s, essentially showing very small differences between treatments, accounting for 1% or less of the variance in patient outcomes. The results are consistent for a variety of disorders, including anxiety and depression. And in fact, when you take into account researcher allegiance, you can do this by looking up the researcher and deciding what treatment they prefer. And you add that as a moderator variable in the meta-analysis, the differences shrink to nearly zero. In terms of dropout rates, the story is pretty much the same. There are no differences across treatments and treatment types in terms of dropouts. In clinical trials, the dropout rates are about 19%. In community practices, the dropout rates are higher, at somewhere around 38%. This next slide is from a network meta-analysis by Barth and colleagues, and there are a number of issues with network meta-analyses, but The picture is, the slide figure is a nice representation of the state of the art anyway. Basically, as you can see, most of the treatments on the far left-hand side, on the y-axis on the far left-hand side, IPT, dynamic therapy, CBT, and so on, are all more effective than waitlist controls. And as you can see, the blue squares indicate the mean effect size for each of the treatments, and they're really not that different from each other, especially when you take into account that 95% confidence interval. So basically, that's a reflection of what I said earlier, that there's not a whole lot, that psychotherapy is effective in general, and there's not a whole lot of differences between the different treatment types. What about psychotherapy and antidepressant medications? Basically, again, based on systematic reviews and meta-analyses of direct head-to-head comparisons of psychotherapy and antidepressant medications, including SSRIs. These are the selective serotonin reuptake inhibitors. Both psychotherapy and SSRIs are more effective than placebo control condition. Psychotherapy and SSRIs don't differ in effectiveness when bona fide psychotherapies are tested. And there are a number of trials conducted by the pharmaceutical industry where the so-called psychotherapy really wasn't meant to be effective. If you remove those, then there's really no difference between bona fide real psychotherapies and SSRIs. This is true for chronic and non-chronic depression, for varying levels of severity of depression. There's some evidence for the superiority of SSRIs for dysthymia, but the effect size are really tiny. Of note, though, psychotherapy has better long-term outcomes at follow-ups. In other words, once you discontinue antidepressant medications, their effects tend to dwindle, whereas psychotherapy does not. The effects of psychotherapy does not. The dropout rates are lower for psychotherapy, and psychotherapies create less resistance to multiple administrations. In other words, there's a tendency for if someone does not do well with a particular SSRI, that they will not do well for that class of SSRIs, and that's not necessarily true for psychotherapy. A particular interest and importance is that in a meta-analysis looking at patient preferences, if you ask patients what would they prefer, if you give them a choice, psychotherapy or medication, 75% of them choose psychotherapy. Now that's important because we know that client preferences are significantly related to outcomes. If patients get what they want in terms of treatment, they're more likely to have a better outcome. But as you saw earlier with that slide that I showed you, the figure I showed you at the very beginning, most people receive medications. So there's a real disconnect between the evidence in terms of preferences and outcomes and what people actually get in terms of treatment. Just a little side note in terms of the issue of publication bias. Publication bias refers to a tendency for either researchers or industry to not publish non-significant results. In other words, there's a tendency to only publish significant findings, not just researchers, but journal editors as well. The pharmaceutical industry has also been suspected of suppression of data of studies that are not favorable to the treatment. In fact, there's a famous study by Turner in 2008, published in the New England Journal of Medicine, that demonstrated this. Basically, in order to get a medication on the market, it has to be registered with the studies assessing the efficacy of the medication has to be registered with the FDA, the Food and Drug Administration. There were 74 FDA-registered trials of antidepressants between 1987 and 2004. 31% of them were never published. And so the effect size of medications, although in the published trials was 0.37, in the unpublished trials was 0.15, and so the adjusted effect size was actually small at a Cohen's d of 0.25. There is some evidence of publication bias in psychotherapy research, but it's quite a bit smaller than you would see in medication trials. And the adjusted effect size ends up being actually larger than what you see in medication trials. So I've covered the issue of the efficacy of psychotherapy. It's effective compared to no treatment. There's not a lot of differences between therapeutic approaches. It's as effective as medications, perhaps more effective, particularly in the long run and in terms of dropout. I want to cover now some issues around common factors. And by common factors, I mean those things that are reliably lead to positive outcomes that are inherent in any therapeutic situation and not specific to a particular type of therapy. And you can group these in three different areas. One of them includes a relationship, which often refers to the therapeutic alliance. The patient factors that include things like severity and preference and credibility and so on, and of the treatment, and therapist factors, which refer to things like empathy and managing countertransference and so on. This is a slide produced in terms of trying to explain outcome variance in patient outcomes. As you can see, a lot of the outcome variance is unexplained, with about 40% unexplained variance, and that's not unusual. If you look at most medical interventions, that's pretty typical. But about 30% of the outcome variance is attributed to patient contributions, in other words, factors in the patient. 12% related to the relationship factors. 8% is the treatment method, the therapist 7%, and then other factors 3%. As you can see, most of the variance is with the patient and with the therapeutic relationship, and not necessarily with the treatment method. My favorite statistic of the talk is that 80% of the National Institute of Health dollars for psychosocial intervention research is spent on evaluating that 8% of the slice of the pie. In other words, there's been a real strong focus on trying to find differences between treatments as opposed to trying to find factors that increase patient outcomes. This is a very brief slide on some of those relationship variables and therapist variables that I was talking about, and the effect sizes from several different meta-analyses. Just very quickly, just to cover some of these, the therapeutic alliance is defined as the agreement of on tasks and goals of therapy and the relational bond between the therapist and patient. There's a meta-analysis done by Horvath of over 200 studies showing a medium effect size. In other words, a good therapeutic alliance assessed early or in the middle or at the end of therapy predicts patient outcomes. There's no differences between treatment types, although the therapeutic alliance functions is an important function in each of the treatment types. And there's some emerging evidence that being able to identify and repair problems in the alliance also improves patient outcomes. In terms of patient factors, there are a number of issues that come up. Remember, this was one of the larger predictors of patient outcomes. So severity of problems, that's a functional impairment or the severity of symptoms, comorbid personality disorder, a history of abuse, all of which are associated with poorer outcomes or premature termination. Expectation and hope, this accounts for a small but significant amount of the outcome variance when patients have a stronger sense that the treatment will be helpful. And of course, coping style, being able to match client coping style with treatment approach seems to be related to treatment outcomes with a moderate effect. And finally, therapist effects. This is therapist differences between therapists seem to have an important influence on outcomes. Some therapists are better at others in terms of achieving outcomes. In fact, it appears that somewhere between 29 and 67% of therapists are reliably effective for the treatment of depression, according to some of the research. Interestingly, the training of therapists to be adherent to and competent to a treatment manual is not significantly related to outcomes. Being adherent and competent to a manual does not seem to improve patient outcomes. It doesn't mean that the treatment is not effective. It means that that particular aspect of the treatment may not be related to therapists' effectiveness with their clients. We do know a number of things about characteristics of effective therapists. An ability to form an alliance across a range of patients, having facilitative interpersonal skills, in other words, empathy, verbal fluency, and emotional fluency, having some level of professional self-doubt, in other words, a healthy skepticism about their own abilities, which drives them to try to do things differently and better, and deliberate practice, which really involves individualized, continuous training in psychotherapy practices. So what are some of the practice-based implications of these findings? Well, psychotherapy is effective for many mental disorders. It's as effective or more effective than antidepressant medications. Knowing this research and these findings is important for therapists. Therapist allegiance and confidence in their work is related to patient outcomes, and patients knowing this research is important as well, because instilling hope in patients also can increase their positive outcomes. The second thing is that bona fide psychotherapies are equally effective for many disorders. Therapies, a variety of different types of therapies with an established psychological theory of the disorder and treatment based on that theory, delivered by a trained professional, is effective for clients. And the third area is that common factors across therapeutic approaches. Again, since there are not very many differences, what are the factors that account for the efficacy of treatments? It might be these common factors, and that includes things like developing an alliance early, maintaining it, and repairing any alliance ruptures. Therapists engaging in deliberate practice, in other words, looking for the client's perspective, particularly on the therapist's empathy, being aware of very negative effects of therapist hostility and confrontations, or treatment rigidity, or in other words, under the general umbrella of countertransference, and systematically collecting session-to-session patient outcomes and using this to inform their treatment. And the third one are patient factors, such as severity, symptom severity, comorbidity, and coping style, and being able to adjust one's treatment approaches and interpersonal style to these patient factors. Just to end, I want to put in a quick plug for the Psychotherapy Practice Research Network. This is a collaboration between University of Toronto Psychiatry and University of Ottawa Psychology to conduct practice-based research in psychotherapy. We've recently received a Canadian Institutes of Health Research operating grant to train community-based therapists to identify and repair alliance ruptures. We'll be putting out a call for community-based therapists to join the study probably in the new year. I produce a free monthly e-newsletter that summarizes the best in psychotherapy research for clinicians. Basically summarize mainly meta-analyses and what the practice implications are for those. It's a very clinician-friendly newsletter. It's free to join the PPR net, and there's the website. Thank you.
Thank you, George. That was wonderful and timely, and the content's surely spot on. I think what I'm going to do, I see there's one question, but I think I'm going to hold questions so that we give Hélène Maria a chance to present, and then we'll do questions at the end.
Mm-hmm.
Okay, perfect. Thank you, Karen. So first, before I begin, I'd really like to thank the Mental Health Commission of Canada for organizing this webinar and for allowing me to and giving me the opportunity to present on my presentation, Ensuring Psychological Services as part of Medicare in Canada. I won't leave everybody too much in suspense. The results of the study did show that it was cost-effective for depression. To change the slides. There we go. So before I begin, I'd like to also mention that the results that I will be presenting today were recently published in Psychiatric Services. So for those of you who want a little bit more detail as to the data that went into the analyses, you'll be able to find, with the appendices, you'll be able to find it in the in that issue of Psychiatric Services, and also some of the tables are at the end of this presentation. I would also like to mention that this was a CIHR grant, and the co-investigators of the study were Dr. Alain Lesage from the University of Montreal, Dr. Eric Latimer, and Dr. Martin Drapeau from McGill University. Just to give you a little bit of a background of how we applied for this operating grant, I had received in 2009 a meetings planning and dissemination grant from the CIHR, which allowed me to go to travel to the United Kingdom and Australia, where I met with decision makers, researchers, and clinicians that had been implicated and had participated in the introduction of publicly funded psychological therapies in their health systems. Following these two overseas interviews, there were two meetings that were held in Montreal, again with researchers, decision makers from the Quebec Ministry of Health and Social Services, the Government of Quebec, members of the Mental Health Commission of Canada. There was also the Canadian Psychological Association and the Order and College of Psychologists of Quebec and Ontario. We also had community organizations and members of the Institute of Health Economics. In these two meetings, we presented and summarized the implementation processes in the UK, the IAPT program, and the Better Outcomes and Better Access programs in Australia. Now, the research team and invited participants then agreed that given there was no need to replicate studies on the cost effectiveness of psychotherapies at the clinical level, but there was a consensus among the members and the advisory committee that the effectiveness of psychological interventions really in real life programs and the cost containment of any increased access scheme would be issues to address, and this always within a primary care system. So with this advisory committee, we submitted the present research project that would be a modeling exercise of the costs and benefits associated with an increase in funding for psychotherapy, and this to inform on how best to allocate resources with the view that there would be, in 3 to 5 years' time, the famous and government transition funds. So here I present the rationale and the arguments we gave within that project, for the project, and the first two arguments are really in line with the perceived, if you will, negative bias towards accessibility of evidence-based services for common mental disorders as opposed to, for instance, physical chronic disorders. So here we know that the prevalence of depression is comparable to that of other common chronic diseases like hypertension and diabetes. Recent lifetime rates in Canada reach up to 11.3%. The disability related to depression is ranked as one of the highest among all diseases. The WHO data have shown these consistently. The attributable costs associated with depression have increased in North America. Greenberg's recent paper showed that these reach close to $210 billion in 2010 costs, and this is similar also in Canada. The Institute of Health Economics had shown that the costs of mental disorders are about a little bit over than $50 billion. But what is important here to mention is that a third of the costs only are attributable to medical and pharmaceutical costs. 2/3 of the costs are really attributable to loss of quality of life that is associated with incapacity, and also due to productivity, loss in productivity associated with presenteeism, absenteeism, and also loss of productivity due to premature death due to suicide. And the other argument was that although modern psychological therapies can cost-effectively supplement or replace pharmacological approaches to treat depression, only 50% of people with depression actually seek services. And this we had also highlighted, and what Dr. Tosca also mentioned, that the majority of patients do prefer psychotherapy as opposed to medications. So now if we change to the other slide, and I'm having a little bit of difficulty, thank you. So just the context also, we are in Canada, it's a gatekeeper, a GP gatekeeper system, and it's not surprising that among Canadians consulting for mental health reasons, close to 80% will consult their family physician. There was a study by Grenier et al. Who had shown that the majority of family physicians are aware of evidence-based psychological therapies. They do know that they exist, but they had mentioned that they felt that they were not trained to offer them, they didn't have time to offer them, or did not wish to offer them. One of the largest barriers that was noted from family physicians for not referring patients who needed psychological services was cost and the lack of public health insurance coverage. In the other slide, I'm presenting just to get a thank you to get a little bit of also a sense of what the some population-based studies have shown us on the issue. Their recent reports have shown that close to 55% of those with depression that do consult in primary and specialized mental health care settings are detected and receive guideline concordant treatment. So, and this is among people, so among the 50% that do consult, 50% receive treatment. There was also an earlier study on the Joint Canada-U.S. Health Survey, which clearly highlighted disparities in treatment seeking among depressed population that was associated with the presence of medical insurance in the United States versus Canada. There was also a study that we had carried out using data from the Canadian Community Health Survey, Mental Health and Well-Being, that was carried out by Statistics Canada in 2002, which showed that the determinants associated with outpatient service use by type of provider had shown that income and education were barriers to consulting with psychologists and other health providers that were able to give psychotherapy, to provide psychotherapy. And we have recent data from the new Canadian Community Health Survey that was carried out in 2012, which showed that 39% of adults with major depression report an unmet mental health care need, and of which 71% is associated with the need for counseling and psychotherapy. There was also recently in 2013, the health commissioner in Quebec that had written a report on the performance of the healthcare system, and they underlined also the inequity in access to effective mental health services, such as very long waiting lists for psychotherapy, and they called for a need to reevaluate resource allocation. So in general, and if you will allow me, all these data that we just saw, one can conclude that what is not insured is not accessible to all. So far, the UK and Australia have decided to reimburse psychological therapies in their health systems. In the UK, there was Lord Richard Layard's cost-benefit analysis of the program IAPT, Improving Access to Psychological Therapies, which showed that the program would pay for itself within a period of 5 years. In France, there was also a similar study that estimated a cost-benefit ratio ranging between 114 and 195. So for every $1 invested, you would get back between 114 and 195. So since in the UK the economic modeling, and now I've passed the objectives, since in the UK the economic modeling exercise was very helpful in the decision-making process of the creation of the IAPT program, the objective of this study was therefore to evaluate the cost effectiveness associated with rendering psychological services as part of Medicare in Canada, and this for individuals with unmet mental health needs. Currently, Canada is examining on how best to use the federal transfer funds, and in the province of Quebec, the Health Technology Assessment Agency, the INES, is currently working on their third report on, there's three, out of a series of three, on the equitable access of psychotherapy. So very briefly for the methods, we used a discrete event simulation to model the evolution of depression over a 40-year period to assess the cost effectiveness of increasing publicly funded access to psychological services in Canada as compared to the status quo. And that is what is happening right now. We included in the model incident cases of depression aged between 20 and 95 years. The probability of events and model parameters were based on epidemiologic, pharmacologic, and cause data from the literature. And we also carried out secondary data analyses of the 2012 CCHS survey data, which gave us a better picture as to how the health service use patterns of Canadians in 2012. So if we go to the other slide, here is really a very briefly, a brief overview of the model. Here, I just want to bring your attention as to the outcome measures of interest that we attempted to measure, and that was, for instance, lifetime hospital admissions, suicide attempts, the number of depressive episodes, and the whether there was recovery, response, remission, and this all depended on the health service use of patterns of this simulated population. So people would enter the model at the age of 20, and they would exit the model at the age of 85, or death due to suicide, whichever came first. So for the results, I'll go to the next table. So here we see, I present the characteristics of the simulated adult population, again with incident depression, and this over a 40-year follow-up period. And you can see here, and just to mention that the base case scenario, which was the status quo, these estimates were used to validate whether the model actually was valid. We compared the data to what was already published in the literature. So what could we see here is that on average we saw a decrease in the number of days depressed. We saw a decrease in the number of days of being suicidal. We saw an increase in the number of days in the well state. And we also saw a decrease in the lifetime risk of hospitalizations. We also saw a decrease in the number of suicides. We did not see a significant decrease if we look at the confidence intervals in the lifetime risk of attempted suicides. So if we go to the next slide, increasing access to psychological services would be associated with approximately $123 million in additional costs to the health system. Now this cost is comes from, or if you will, is based on the formula that I'm showing here. It's the $1,292. So this is based on assuming that a person would see their GP twice within the year and have 8 psychotherapy sessions. So the first visit to the GP would be to get the referral, the consult and get the referral to the psychotherapist, and the second follow-up visit with the GP would be for the follow-up visit and reorientation of the clinical treatment, if you will. So this is actually what is, if you want, the Australian, we use the Australian model here. The savings to society using the human capital approach would reach on average $247 million. So if we go to the next slide, the previous slide. Thank you. And I apologize, everyone. I'm having a lot of difficulties with my slides. So if, in conclusion, increasing access to adequate psychological services in the population yielded a significant decrease in the number of days in the suicidal and depressed state with an increase in the number of days in the well or healthy state. Now this translates into an average benefit of 0.17 quality adjusted life years gained per person. So increasing access to psychological services we see also shows a decrease in the health system and societal costs. We can see this in the first lines of the table. The incremental cost-effectiveness analyses did show that increasing access to psychotherapy dominated the status quo. That is, it was more effective and was less costly. The sensitivity analyses show that the most important influence on results was the use of the friction cost method and human capital approach in assessing loss of productivity. If we go to the next slide. Okay, so if we go to the discussion. So if one were to consider now covering psychotherapy sessions for all Canadian adults with incident depression, and that is about 2.9% of the population, the program would cost approximately $1 billion. In Australia, in the first 3 years of the Better Access program, close to 2 million individuals had received approximately 11 million psychotherapy sessions for an average of about 6 sessions per individual. And this for a total a budget or expenditures reaching about $280 billion or $1,500 per individual. In the UK, the cost of the IAPT program was estimated at £600 million to treat about 800,000 patients that had opted for psychological therapies in 2006. Recently, the NHS invested an additional £400 million in the IAPT program, and this to offer services to children, adolescents, older adults, and people with severe mental health and chronic physical problems. In France, the yearly cost of covering 12 psychological sessions for depression and anxiety disorders to cover 2.3% of the population reached about $730 million. Now this estimate is lower than the one we observed, and one of the reasons for this could be attributed that a psychotherapy session in France costs about 41 euros, which is about $65 Canadian, as opposed to an average of $145 in Canada. So what are the implications of covering psychological services as part of Medicare in a public health care system? And I bring here the one of the worries and the examples of what happened in Australia, where there was great concern surrounding the increasing costs of the Better Access program, where costs really rose to $1 billion within the first year, and many argued that the program was actually widening the socioeconomic gap in mental health service use. But Harris and colleagues in their study actually showed that 90% of Better Access users had a 12-month ICD mental disorder. Those without an affective or anxiety disorder that were actually were using services were not from higher socioeconomic groups, and those with a mental disorder received significantly more services than those without. Now, what would one want to consider for a successful health policy, and this aimed at improving access to mental health services? And I'm on the other slide now. And this was a comment that I had received from one of the reviewers of psychiatric services. And Richards and Bauer really, in their discussion paper, really underline the issues of access, who will get treatment, equity, type of service offered, cost effectiveness, and that is, are health outcomes improved at a sustainable cost, and patient-centered care. Is the service meeting individual mental health needs? Which brings us all to questions of the need for evaluating these programs and access to psychotherapy in real-life settings. Now, I know that we don't have much time. I will go through very quickly now to the conclusions. There are limitations associated with the study that you could maybe appreciate a little bit later or ask me during the question period. And just to conclude, that for covering psychological services as part of Medicare in Canada would also pay for itself. For every $1 invested in the program, that would yield on average $2 in savings to society, and these estimates are similar to what we observed in the UK and in France. And I'll stop here. Thank you.
That's terrific. Thank you so much. Hélène Maria and George, for your terrific presentations. We have just, it looks like 10 minutes, but we do have a few questions, and we could probably get to either all or most of them. First one first, I think the first question raises an interesting issue. Is actually one of the questions I thought of as well. Sort of the difference between effectiveness research or research using real-world patients or efficacy research maybe, and which is research done on folks in the lab. So the question is the mega effect size of 0.80, and I should mention this is for George, for clinical trials or community practice? So that's for you, Dr. Tosca.
Yeah, so that effect size was for clinical trials. However, as far as we know, and it's actually hard to look at this, but as far as we know, there's no significant difference between the effect sizes that we see in clinical trials and what we call effectiveness trials, or trials that are more closely similar to what happens in real life practice. John Hunsley here at the University of Ottawa did a review of that several years ago, and really found the effect sizes to be very similar between clinical trials and clinical practice effectiveness studies. And so I would say that 0.8 is probably a reasonable estimate of clinical practice as well.
Thank you. Thank you for that. There was another question which I think makes a really good point. Maybe I'll just quickly speak to it, and then perhaps George or Hélène Maria, you may have comments as well. And the point is that really low-income and marginalized people who have very complex needs and may need and benefit from individual psychotherapy really don't have that option in the public system. I'll just add that as an association, this is something we've been advocating for some time, is that Canadians deserve better access to care that works from providers trained to deliver it. And delivering it in tertiary care facilities that's where the funded door is, but it may not be where the treatment is provided. And so I think all stakeholders in mental health, and in that I would include the health professions as well as the users of service and families and communities, need to continue to make that point to government and other funders. Maybe Hélène Maria or George, maybe you'd like to comment on that point?
No, I don't have any more comment. I agree with what you're saying. I think it's important to be able to reach low-income and marginalized individuals.
Agreed, and the issue here would be then, and what you, going on what you said, Karen, maybe, and how to facilitate access towards primary care within the primary care and not tertiary, and that is the issue, accessibility within the primary care.
Yes, absolutely. So leading for that, these questions segue beautifully from each other. There was a question related to initiatives in Ontario and what suggestions our two speakers might have for defining what psychotherapy is for the purpose of regulating and funding it.
I can speak to that. I think there's a long-standing misconception that one type of psychotherapy is more effective than others, and so people conflate the term psychotherapy with cognitive behavior therapy, for example. CBT is an effective psychotherapy, no doubt about it, and there's a lot of research on it, but it's no more effective than other bona fide psychotherapies, and so to limit funding to one type of psychotherapy, which may be the case in Ontario, I think is a mistake. And I think there should be a broader definition of what's effective psychotherapy. And the other comment I want to make about that is that the real bang for your dollars is not in the types of psychotherapies, but in training therapists to be effective therapists. That's where client outcomes where we're going to see the greatest increases in client outcomes.
If I could just add to that, George, the opposite is always true. Not everything that anybody does in the spirit of offering help is necessarily psychotherapy either, or effective psychotherapy, or evidence-based psychotherapy. So just as there's an evidence base for different approaches, not everything that's offered is necessarily psychotherapy. So that would be one important point. And I guess the other point I would make about initiatives, whether that's Ontario or in other provinces, is that there's this great tendency to sort of devise these one-stop-fits-all solutions to mental health, as if there's only one way to approach it, one service that's going to work for all the mental health issues and challenges and disorders out there. And I think that, too, is problematic. It's not the case. The needs of an adolescent or a senior or an adult, the needs of persons with different kinds of disorders will vary. And then finally, I just want to underscore the importance of assessment and triage, so that we in fact make sure that the right treatment reaches the right person at the right time in the right place. Elaine Maria, would you like to add to that question?
No, you said it very well.
Okay, great. So just making our way through the questions. There's one more. We have a couple more minutes. There's a few more. In these studies, I'm not sure whether this was directed to George or to Elaine Maria, was there any comparison of individual versus group treatments? Can you speak to the different efficacies there?
Yes. There's actually a lot of misconception about the efficacy of group therapy. There's a very good large meta-analysis done by Gary Burlingame, published very recently in 2016, covering trials over the last 25 years. Basically, there's no difference between group and individual psychotherapy. My group just published a meta-analysis for eating disorders, and again, no difference between group and individual psychotherapy. So I think the results are fairly clear, and hopefully that question will be put to rest.
And the issue to that, if I may, is that, and if it is so, then one can argue also then that the costs surrounding that, so giving a therapy to groups versus individually for those who will respond within groups, could also be, from an efficiency point of view, very interesting.
I agree with that. The only caveat is that training programs, clinical training programs, tend not to provide training in group therapy. It's relatively rare. Generally, clinicians get group therapy training at a postdoctoral level as continuing education. And so if we really wanted to make use of the efficiencies in group therapy, then training programs would have to shift some of the training towards training for group therapy.
I think we have time for one more quick question, and sorry I couldn't get to everyone, but I think I've probably gotten to most. But I guess one of the questions here is really, there's a great burden perhaps on not-for-profits who actually provide mental health services in communities who maybe already run programs that are scaled to income. If we were to really look at expanding services to make psychotherapies, psychological services more accessible, where would the burden lie? How would we do that? How would we fund it? Where would we put it? Either of you, George or Ellen Maria.
So you're asking where would you put the funds in order to provide greater accessibility?
Where would people go to receive it? Would the burden be on already not-for-profit services? Would it be on individual providers? Like, where would patients ideally go to get this enhanced access?
So the typical entry point is with the family physician.
Mm-hmm.
And so I would say that, an emphasis on providing psychotherapy services within the primary care setting in order to reduce barriers around travel and access and all of that. I think that would probably make the most sense, rather than putting it in some other context or institution that may be harder to get to. I think if we put it right where the patients go, which is the family doctor's office, I think that's probably the best solution.
Ellen Maria, you get the last word.
I agree, and that's the answer I would have given, which follows exactly what Australia did and what the UK did, with the only maybe difference here, and it is one of questions for the future, is in the UK, for instance, you have also self-referrals for psychological services as opposed to going through the GP, which could be also another point to also look at.
I agree with that.
I think we've gotten to almost all the questions, but we're at time. Thanks again to both of you. Did an outstanding job. And I'm sure each of you, I'm going to speak for you now, wouldn't mind getting any follow-up questions if there were any directed to the Mental Health Commission?
Yes, that'd be great.
Okay.
Definitely.
Great.
Yeah, this is Lara from the MHCC, and I just want to echo Karen's thank you. Thank you so much to all three of you for doing such a fantastic job in this outstanding discussion today, and thank you for your questions. I just wanted to take an opportunity to remind participants that there will be a second webinar that will explore approaches to funding expanded access. Stay tuned for an announcement on the date, but it will be held towards the end of October. I also wanted to ask that people please take a moment to fill out our survey that will pop up on your screen after you leave the webinar. So this is especially important if you would like to continue to receive invitations to our monthly webinar series. For privacy reasons, you must complete the survey and let us know that you would like to be contacted about future webinars and events. So it will help us get in touch with you to invite you to our second webinar. So once again, thank you so much to Dr. Giorgio Tasca, Dr. Helen Maria Vassiliadis, and Dr. Karen Cohen. A special thank you as well to my colleague Benita Varga for her incredible assistance today. If you have any questions, as Dr. Cohen mentioned, please do not hesitate to contact our presenters today. And if you have questions for the Mental Health Commission, please do not hesitate to get in touch with me. We really look forward to continuing this series, and have a wonderful day.
Great. Thank you.
Thank you.
Thank you.